بسم الله الرحمن الرحيم. مساء الخير جميعا وألف مرحب بكم for this session of thyroid update series done and masterminded by very eminent people in collaboration with the Arab Thyroid Association. Tonight we are going to have very important, actually, sort of two presentations. One of them about thyroid disorder in pregnancy, an overview from Dr. Mohammed Bashir. Mohammed Bashir is senior consultant endocrinologist and director of diabetes center in the Well Women Hospital and Research Center, part of Hamad Medical Corporation in Doha, Qatar. And my humble self is also senior consultant in the endocrine section, and we work together actually in the same section. My name is Tariq Abdul Karim Al-Had. I'm pleased to be moderating this very important session. We all know that, thyroid disorder in pregnancy is the second most common endocrine disorder during pregnancy after diabetes in pregnancy. And our second esteemed speaker is another very distinguished and eminent endocrinologist who also works with us in the endocrine section, Hamad Medical Corporation, as a senior consultant, Dr. Imad Naim. Dr. Imad Naim, following the presentation of Mohammed Bashir, will discuss what to do regarding thyroid nodules if they are looking suspicious in a pregnant lady. With further ado, I would like to hand over the center stage to Dr. Mohammed Bashir. Mohammed Bashir, the platform is yours. Mohammed, you are mute. Please unmute, Mohammed.
Okay, Tariq. Thank you, Tariq, very much. Can you see my slide?
We do see your slides.
Great.
And we hear you very well. Carry on, Mohammed.
Great, thank you very much. So once more, thank you, Tariq, and thanks to the Arab Thyroid Association for the invitation. And these are my disclosure for the talk. So the bulk of the talk is gonna run around the latest guidelines in thyroid disorders in pregnancy, and that was published 2017, with few updates of few recent studies that came after these guidelines. So as a start, in pregnancy in particular, it's very critical to understand what's a normal and abnormal thyroid function during pregnancy. But it's very critical as well to understand the central role that thyroid hormones plays early on in the fetal development. And it seems the most important and critical parts that the thyroid hormone plays is in the placental formation, the maintenance and growth of the placenta. That happens pretty much in the first few weeks of pregnancy, in addition to the impact on somatic and brain development. We know that for the mother, the thyroid hormones are critical determinants of metabolic activities of all the organs. And it's very critical that a state of euthyroidism is actually achieved early in pregnancy, should be achieved before pregnancy, but achieved early in pregnancy and maintained throughout pregnancy. So generally speaking, pregnancy is a stressful time for the thyroid gland, simply because there are multiple physiological changes that impact the thyroid function the way we know it. So the marked increase in the thyroid binding globulins impact the FRET, which is induced by the estrogen, leads to an increase in the thyroid binding globulins, which basically sucks the FRET4 from the circulation, and hence there is a decline of the FRET4 throughout pregnancy. But overall, the total T4 is actually increased. However, if you just need to pay attention that the FRET4 is actually on a decline throughout pregnancy. In addition to that, HCG, who shares similar homology with the share the same alpha subunit and similar homology with the beta subunit, has the ability to stimulate the TSH receptors. And at the start of pregnancy, due to the rise in the HCG, the HCG stimulate the thyroid gland to produce free T4, and there is pretty much no need for the TSH, and hence the TSH goes down early in pregnancy, and midway in the second trimester, the TSH start to come back to normal. So this is very critical because in about 10 to 20% of the women, the TSH is normally low or completely undetectable early in pregnancy, and that's part of the changes that happen, neurophysiological changes. But generally speaking, the thyroid hormone production is increased by about 50%. Particularly, there is a 30% increase in the first month and gradually increases in the third month, and then it plateaus down. It comes down after that. And this schematic, this actually just pretty much summarizes what I just said. A hike in the HCG is associated with a drop in the TSH, and an increase in the total thyroid binding globulin leads to a reduction in the free T4. So what will be the best test for us to screen for thyroid disorders in pregnancy? Generally speaking, we have two tests that we do. We do the TSH, which is most of the time currently is an immunoassay, which directly measures the TSH. And this is the most sensitive test even outside pregnancy, but in pregnancy in particular, it is more sensitive than any other test. And there is a good correlation between doing the test in different platforms, as long as they're using the same, using immunoassays. However, the free T4, we don't have standardized assays to measure free T4. And in actual fact, we do not measure free T4, we estimate free T4. The only way to measure free T4 is through direct equilibrium dialysis, which is time consuming, or mass spectrometry, which is not available everywhere. And this estimate is a protein dependent, and it's affected by alteration in albumin and globulin. And as I said, there is no standardized way. And hence free T4, due to the changes of albumin and globulin that happens throughout pregnancy, becomes a more inaccurate test to screen for thyroid disorders in pregnancy. And using different platforms, there's a very poor correlation between them. So whenever you're managing a thyroid patient during pregnancy, you need to stick to one platform throughout the pregnancy. Otherwise, it will be confusing. So generally speaking, it's hard to come up with a normal range for free T4, as I just outlined, due to non-standardized assays available. However, the question will be, what will be the normal TSH range during pregnancy? And I'm going to go back here in history to the previous guidelines that were pretty much aligned, all of them, that the normal range in the first trimester ranged between 0.1 to 2.5 milli-international unit per liter. And obviously, that will mean that any woman who have a TSH above 2.5 milli-international unit per liter with a normal free T4 will fill with the level of the criteria for subclinical hypothyroidism. And that was a huge issue, because if you looked at population-specific readings, normal ranges, most of the population upper limit of normal was much higher than the 2.5. And if you applying these levels to the different populations, just made the prevalence of thyroid disorders, particularly subclinical hyperthyroidism, to soar, and medicating a large number of patients. The other side as well, which is the lower limit of normal, was much lower than the 0.1. Majority of them rang around the 0.05 milli-international unit per liter. But remember, we're talking about 10 or 20% of the women normally who will have a completely suppressed TSH. So what the American Thyroid Association advised us to do is to subtract the lower, in the first trimester, subtract the lower limit, 0.4 milli-international unit per liter from your lower limit of normal. So if your lower limit of normal in your assay is 0.45, for example, then you subtract 0.4 from it. And that gives you a range of about 0.05. You keep the upper limit of normal at 4 milli-international unit per liter. And hence, in the institute we work in, we're estimating, we're using this cutoff point as the range during pregnancy, which is a 0.05 to 4.0 milli-international unit per liter. And this is critical because we receive a lot of referrals of a TSH that is sent as low, And in actual fact, they're within the normal ranges. So I'm gonna go now and talk about hypothyroid disorders in pregnancy. And before I go that, because that's the most common condition that we treat during pregnancy, let's go and understand a few things about the fetal hormone production. Because as I said, the thyroid hormone early on is very critical for the fetal development, and the fetus is not able to produce any thyroid hormone till about 18 weeks of gestation. And by about 22 weeks gestation, the fetus production increases quite significantly, and the fetus will start to deactivate or break down the maternal thyroid hormone and use that to get iodine out of that. So generally speaking, the fetus, as I said, is vulnerable for thyroid disorders early in pregnancy. And that's why, as I said, we need to achieve euthyroidism early on, better to be achieved before pregnancy and before conception. And hence the pre-pregnancy optimization is very, very critical. And that will tell us, as I'm going to show you later on, the screening for hyperthyroid disorders after the first trimester is probably meaningless. So what are the adverse effects of the hyperthyroid disorders in pregnancy? And I'm talking about overt hypothyroidism here, not subclinical. So majority of the impact is related early on to infertility and subfertility, miscarriage, and hypertensive disorders in pregnancy, and abruption, and other complications. But if you pay attention to what the function of the thyroid hormone mainly around, and as I said, it seems to be mostly focused on the initial development of the placenta, miscarriage and hypertensive disorders are all related to placental disorders. And for the babies, there are multiple studies that linked different outcomes, but most of it is an early loss of pregnancy. That is the most common one, but there are multiple other complications that have been reported, but not replicated in most of the studies. So when managing an overt hypothyroidism early on, as I said, it's critical to achieve euthyroidism. That will improve the chance of the woman getting pregnant, will reduce the rate of early miscarriage, and that's critical. And the target is to keep the TSH under 2.5 milliliters unit per liter early on. So, and as soon as the woman gets pregnant or conceived, the dose has to be increased by 30%. And if you recall, I told you early on that the normal thyroid would increase the production, thyroid gland increases its production rate by 30%. And a 30% dose is adding 2 extra doses a week of whatever dose she's on. If she's taking 50 micrograms a day, for example, 7 days a week, she needs to take an extra 50. You can spread it throughout the 7 days, so extra 100, is spread throughout the days. So you can take, say, 50, 5 days and 100 micrograms 2 days a week. So, and before we go any further here, what medications do we use when we're treating thyroid disorders in pregnancy or overt hypothyroidism? In this case, we use levothyroxine. We don't use T3, triiodothyronine. So the T4, the levothyroxine, has a half-life of 7 days, and food interferes with its absorption. So there are multiple things that we need to know. Because of the half-life, which is quite prolonged, in order to achieve a steady state, you probably need about 4 weeks in order to reach a steady state. So if you're starting levothyroxine therapy outside pregnancy, we normally wait for 6 to 8 weeks. In pregnancy, the minimum time to wait is 4 weeks. Don't adjust before that because the TSH have not reached the plateau level yet. So 4 to 6 weeks is the usual range. Levothyroxine has a very narrow therapeutic index. So missing a single dose can impact the TSH severely. So the woman has to be educated about replacing any missing doses. So she missed a dose on a Saturday, for example, on a Sunday, she has to take she has to take 2 doses in order to compensate for any missing dose. And that's very, very critical. And well, if you have very incompliant patients, you can split the doses. You can give it once weekly, possible. You can give it twice or 3 times a week. And as I said, food interferes with it. So the best way is to be taken on an empty stomach, 30 to 60 minutes before breakfast. I normally tell them, if you wake for Fajr, take it at Fajr prayer. You can take it 3 hours after meal, and that's what I tell them to do during Ramadan. Or you can take it just before going to bed, as long as that was 3 hours after the last meal. So you have multiple options to offer to the patients. So during pregnancy, as I said, we always aim for a TSH of 2.5. We monitor every 4 to 6 weeks. And then from 20 weeks, you can ease things off. However, once they achieve 26 weeks gestation and they're euthyroid, we don't need to follow them any further. I told you by 22 weeks, the fetal thyroid hormone becomes, the fetal thyroid requirement becomes independent from the mother, and they are self-sufficient. Once they deliver, we put them back on their pre-pregnancy dose, and then they could be seen in 6 to 8 weeks. Now, how about newly detected hypothyroidism in pregnancy? And that has a definition that is a TSH that is above 4 and a free T4 that is low. That is what the way we diagnose it anyway. But in pregnancy, we define hypothyroidism in addition to that as a TSH that is above 10, regardless of what the free T4 is like. So that's a different from the definitions that we do outside pregnancy. So if a woman, so whenever you find a test that is abnormal, just send a confirmatory test before start any form of treatment. And for a woman who is newly detected with hypothyroidism, we do exactly the same. I normally start with a 50. I don't go any lower than that. And then we do the same. See every 4 weeks till which is stable. Aim for a TSH of 2.5 milliinternational unit per liter. And once we achieve euthyroidism, and if they pass the 26 weeks and everything is fine, we can discharge them. We normally reduce the dose by 30 to 50% post-delivery, and they review them in 6 weeks' time. Now, subclinical hypothyroidism is defined as a TSH of above the upper limit of normal, but under 10 with a normal free T4. So subclinical hypothyroidism is a controversy. There's a lot of controversy about it, and it's due to many things. If you looked at the literature, they are defined in different ways, and they're defined at different gestational age throughout the clinical trial. So the not homogeneous definition for what's subclinical and when to intervene. And because of that, you find multiple guidelines, multiple studies that showing different outcomes. But what stands out is a high level of pregnancy loss in those patients. And if you look at some of the studies that focus on subclinical hypothyroidism and looked at treatment versus no treatment, and this is one of the most famous one, the treatment of subclinical hypothyroidism was shown to reduce the risk of miscarriage in those patients with subclinical hypothyroidism. However, the mean age for starting levothyroxine was 9 weeks, and all the miscarriages occurred less than 11 weeks. And as I just told you, it doesn't make sense here because the LT4 has not even reached its steady state yet. So the relationship wasn't 100% clear. There are other meta-analyses and observational studies and randomized control trials that are full of bias and lack of blinding or randomization. But majority of these studies actually showed, if you put them together, showed that there is increased risk of early pregnancy loss, particularly which is miscarriage. So recently we have a meta-analysis that looks at the recent guidelines based on the recent cutoff points, which basically looked at randomized control trials and cohort studies that showed pretty much no strong evidence of benefiting of treatment subclinical hypothyroidism on maternal outcomes. The main thing that could have any form of benefit was a reduction in miscarriage, preterm labor, gestational hypertension, and small for gestational age. And all of these are linked to one thing, which is a placental insufficiency. There was no difference between anti-TPO positive or anti-TPO negative. And good thing that there was no difference in child motor or social or behavior development, whether you treat or not treat. So as things stand here, subclinical hypothyroidism treatment, the only benefit seems to be in the reduction of miscarriage and improving placentation and avoiding complications related to poor placentation. And all of these happens early in the first trimester. So the question is, should every woman get screened early in pregnancy if they're not known to have hypothyroidism? And the answer is, well, no. You don't need to screen everybody because there is no benefit of treating subclinical disease with no symptoms. And if you are going to screen anybody based on the guidelines, you should only screen in the first trimester and don't go any further than that. And if this is diagnosed, they get treated exactly the same way as newly detected hypothyroidism. Confirm the test. 50 micrograms are usually starting dose aim for a 2.5 milli-international TSH, and then monitor till the euthyroid. But once they deliver, we stop the treatment and follow them 6 weeks down the road to see if this is going to persist or not. Hyperthyroid disorders in pregnancy is going to be challenging a little bit to squeeze in. So anyway, so pre-existing hyperthyroidism during pregnancy is associated with multiple complications, including reduced fertility rate, early rate of miscarriages. But what's critical is that the treatment that we use can increase the risk of congenital malformation. So it's critical that we make sure that the woman is euthyroid before pregnancy. Better to be on no treatment. If not possible, she needs to be on the lowest possible dose. And if she insists to get pregnant, it's better to use PTU, propylthiouracil. So newly detected hyperthyroidism in pregnancy, the definition here that the TSH must be undetectable and the free T4 must be elevated. So as I said before, a free T4 that's normal with an undetectable TSH is normal in pregnancy. So you have to have the two together in order to diagnose free T4. And hence, this condition of subclinical hyperthyroidism in pregnancy, hyperthyroidism, it does not exist in pregnancy. So if the patient is newly detected, newly detected hyperthyroidism, the common cause is actually gestational thyrotoxicosis, followed by Graves' disease. The rest are very rarely seen in pregnancy. So just what is gestational thyrotoxicosis? I told you about the HCG levels that stimulates the TSH. So early on, due to very high HCG levels increases the levels of nausea and vomiting. So women present with hyperemesis, and HCG stimulates a high level of free T4 and the TSH is suppressed, but there is no signs or symptoms of thyroid disease. And this is usually a self-limiting condition. What's really important is we have a test, which is anti-T receptor antibodies that should be tested. And if it is negative, you ruled out Graves' disease, which is the second most common condition. And the treatment here is supportive. And you don't need to give any other treatment for those patients. So if you want to look at Graves' disease management, so Graves' disease management, so treating patients with carbimazole and PTU put the mothers at risk of the complications related to these conditions. And for the fetus, these medications can cross the placenta freely, and they can use a congenital malformation. One of them is known as aplasia cutis, which is very, very rarely seen. But after that, after the fetus starts to have a functioning thyroid gland, they can cross the placenta and suppress the fetal free T4 production and can cause a goiter. So, and the other thing here is the anti-T receptor antibodies in Graves' disease that could be both stimulatory and inhibitory. Most of the time they get normalized during pregnancy. Again, they can cross the placenta freely, and they can either cause fetal hyperthyroidism or fetal hypothyroidism. So it's critical that we measure those anti-TRAb early on in pregnancy and measure them at 22 weeks gestation, where the thyroid function is at its peak, early peak of the fetus. And if they are 3 times the upper limit of normal, then the fetus is at high risk of fetal hyperthyroidism and should be monitored closely by an ultrasound scan. So what should we do with those type of patients? If you treated them, as I told you, there is risk for the mother and the fetus. If you left them alone, there is risk of complications to both the mother of the fetus due to uncontrolled hyperthyroidism. So you need to have a very delicate balance here, because to avoid all these complications. So if the free T4 is normal early on in pregnancy, we need to use the lowest minimal possible dose or stop the treatment altogether and continue to monitor the TFTs on regular basis. There should be no attempt to normalize the TSH, and the free T4 could be left to up to 1.5 times the upper limit of normal, as long as the mother remains symptoms-free and not at tachycardic and is gaining weight. So she needs to be assessed clinically. Now, if you have to use any treatment, then PTU is recommended in the first trimester, and then move on to the carbimazole onwards using the lowest possible dose. If you exceed 20 milligrams of carbimazole, the fetus has to be monitored for signs of hypothyroidism. And as I told you about the anti-TRAb, you need to monitor, particularly in the second at 20 weeks onwards. And if it's more than 3 times upper limit of normal, you need to start treatment. What's critical here, that 60% of the patients will have a normal anti-TRAb and the TFTs will go back to normal. And we looked at our own data and the rate is actually higher than that. 70% of the patients come off treatment in our cohort. So the last part here, for the sake of time, is looking as euthyroid patients who have an anti-TPO positive, and they had a previous pregnancy complications, particularly recurrent miscarriage. And there's always been a debate about should they be treated with levothyroxine or not. And now we have two studies that have been published over the last few years. One of them was done in the United Kingdom that looked at a large number of patients who had complications before and randomized them to treatment or no treatment. And what they just show that there was no difference whatsoever in the rate of live birth, miscarriage, or any form of pregnancy outcomes. So it didn't matter if you treat those women at all. But this study was replicated in other countries, in the Netherlands, Denmark, and Belgium. Smaller numbers, but at least it showed exactly the same, that LT4 did not improve live birth rates. So at this point in time, treating euthyroid anti-TPO positive women has no evidence to support it, and they should not be routinely treated with levothyroxine. So I came to the end of my talk, and I hope I've convinced you that the management of hyperthyroidism during pregnancy requires an understanding of what the physiological changes that occur throughout pregnancy in order to avoid over-treatment or under-treatment of these patients. And the key part of the care for the woman with thyroid disorders starts before pregnancy. She needs to be optimized before they start the pregnancy, because the critical time is the first 13 weeks of pregnancy. And it's very critical to have your own reference ranges, or at least agree on what is going to be the reference range in pregnancy. And I stop here, and thank you.
Thank you very much, Mohammed, for a very comprehensive and very crisp presentation. We'll leave the questions to the end, following Dr. Imad Naim. Imad is going to talk to us about management of the suspicious thyroid nodules during pregnancy. Imad.
Yes. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for the nice introduction. Also, I would like the Arab Thyroid Association for giving me the chance to participate in this program. I'm going to share my slides now. All right. Do you see my slides? Dr. Tariq, do you see my slides?
Yeah, we see your slides, Imad.
Okay. So my task tonight is to discuss the management of thyroid nodules during pregnancy. I have nothing to disclose. First, we're going to learn how to approach a patient or a pregnant woman with a thyroid nodule, then how to use the ultrasound pattern to guide the decision of thyroid biopsy. Then we're going to discuss the timing of thyroid fine needle aspiration and thyroid surgery. And finally, we're going to identify some red flags that should prompt urgent thyroid FNA followed by thyroid surgery. So I'm going to start off with a case from my clinic. I've seen this young lady in 2017. She's an 18-year-old Syrian female who was referred for suspicious thyroid nodules. She was 9 weeks pregnant when I saw her in the thyroid FNA clinic. Her TSH was normal, and she presented with the neck swelling. She has very suspicious thyroid nodules, as well as suspicious cervical lymph node. So as you see here in this image of the ultrasound, she does have two nodules on the left side. One of them is around 2.5 centimeter. And as you see here, this nodule is very close to the esophagus. And another nodule, actually smaller, around 1.2 centimeter, was close to the strap muscles, and maybe there was a breach of the capsule close to the strap muscles. The patient also has suspicious cervical node, as you see here on the ultrasound. there was a suspicious cervical lymph node close level 3, which is close to the supraclavicular area. The cervical lymph node looked heterogeneous with very vascular and disordered vascularity, actually, which makes it very suspicious. So the question, how should such a patient be evaluated and treated during pregnancy? A little bit of history. Abu al-Qasim al-Zahrawi from Al-Andalus was the first physician who performed needle biopsy from the thyroid gland, and that was in 1961 AD. As Dr. Bashir mentioned earlier, the thyroid gland changed during pregnancy. There is adaptation during normal pregnancy. We learned during medical school that the thyroid gland volume and nodule may increase during pregnancy. However, it looks like this is only applies in iodine deficient regions. So we have data from the United States where the iodine is usually sufficient. It shows that the thyroid gland remain stable in size, same thing with the thyroid nodule. So any change in the thyroid gland size and nodule size during pregnancy in iodine sufficient area should warrant further investigation like ultrasound. So how to approach a pregnant woman with a thyroid nodule? The answer comes from the 2017 guidelines of the American Thyroid Association. So in general, the guideline says the pregnant woman who was found to have a thyroid nodule during pregnancy should be evaluated the same way if she's non-pregnant, i.e. we need to get a TSH level and we should get an ultrasound. The only thing different, if the patient has suppressed TSH, we should not do a thyroid uptake and scan because it's contraindicated during surgery. And the indication for thyroid fine needle aspiration are the same like non-pregnant patient. So basically, if you have a patient during pregnancy presenting with thyroid nodule, you would get at TSH level. If it's normal, you do the ultrasound followed by biopsy if indicated. However, if the TSH is suppressed, which could be related to the pregnancy, like Dr. Bashir mentioned, you wait until 16 weeks. If patient TSH back to normal, then you proceed with biopsy if indicated. If she still has suppressed TSH, you postpone the biopsy till after delivery and get thyroid uptake and scan. And usually we use the ultrasound pattern to guide the decision of thyroid FNA. So we look for suspicious features on ultrasound. The hypoechoic nodules are more suspicious. Solid nodules, irregular margins, the presence of microcalcification, taller than wide on transverse view, and finally, very vascular nodules are suspicious as well. And this is a table from the American Thyroid Association. And as you see, cystic nodule won't need biopsy. And as the nodule becomes suspicious and more sizable, biopsy will be needed. For example, like the nodule on the who are very suspicious or high suspicion pattern, the chance of malignancy is 70 to 90%, and usually recommend to do biopsy if the size above 1 centimeter. Those nodules are hypoechoic, they have microcalcification, irregular borders, and taller than wide on transverse view. They are vascular, and sometimes they are associated with abnormal cervical lymph node. So the American Thyroid Association guidelines says if the patient newly diagnosed with thyroid nodule during pregnancy, if they have non-suppressed TSH, we should do an ultrasound, and the timing of the thyroid FNA should be discussed with the patient, and based on the patient risk of cancer and the ultrasound pattern, as well as the patient preference, biopsy should be recommended during pregnancy. So when I have a patient, usually in my clinic, pregnant with thyroid nodules, I would do an ultrasound. If it's low suspicion, I don't see like red flags, I usually mention it to the patient that she has low risk of cancer, and most of the time we defer the biopsy till after delivery. However, if the patient want to have the biopsy done, we usually do it. So the question here, what is the prevalence of thyroid cancer in women with thyroid nodules during pregnancy? And the other question, is it safe to perform thyroid FNA during pregnancy? This is a study from Mayo Clinic, and they have actually a subgroup of pregnant women, 40 pregnant women who underwent thyroid fine needle aspiration. The malignancy rate was 8%, which was comparable to 7% of women in the same age group. The most important thing, there was no maternal or fetal complication. So number one, chance of malignancy in thyroid nodules is the same, pregnant versus non-pregnant, and thyroid FNA is safe during pregnancy. How about thyroid surgery? Is it safe to perform thyroid surgery during pregnancy? One of the study actually done around 2009, it showed that there is a little bit higher risk of thyroid surgery during pregnancy. They had about 201 pregnant women who underwent thyroid and parathyroid surgery. And they found that the pregnant women were twice likely to have surgical complication comparing to non-pregnant, especially if they have thyroid cancer. And the other risk factor was the experience of the thyroid surgeon. So that was actually something that raised, the safety of doing the thyroid surgery during pregnancy. Again, a lot of criticism to this study, some of the surgeries were urgent, and also the experience of the thyroid surgeon was an issue in this study. So the other question about the timing of thyroid fine needle aspiration and thyroid surgery. We have a very important study from Musa and Muzaffari. It was a retrospective study done on 61 patients. 77 of them, they had the thyroid surgery during actually 77% of them, they postponed the surgery till after delivery. And actually they looked at the recurrence of the thyroid cancer and the distant metastasis 20 years after that. So two groups, one group had the surgery during pregnancy, and then the other group, which is 77%, they had the surgery after delivery, and they found no difference in terms of thyroid cancer recurrence or distant metastasis. So because of the data I just presented to you, the American Thyroid recommendation recommended for thyroid cancer detected during early pregnancy, we should not be aggressive if it's a low-risk cancer. So we can monitor by ultrasound, and if there is no significant change in this low risk cancer, those patients can be followed, and they should have the surgery after delivery. However, if the thyroid cancer is advanced, showing increasing in size or presence of distant or local metastasis, those patients should go should go for surgery during the second trimester. Again, that was a weak recommendation, but I think this is what the standard of care at this point. So what are the red flags that should prompt us to do thyroid biopsy followed by thyroid surgery during pregnancy? Number one, if there is presence of extensive nodal or distant metastasis. So this is aggressive tumor. We should not wait till delivery. We should interfere. Also, if it's like a small cancer and we follow during pregnancy, and we show by ultrasound more than 50% increase in volume. Again, this is locally advanced cancer, and it should be treated during the second trimester. Other concerning ultrasound features, if we see that the nodule itself is close to structure like to the esophagus, to the trachea, or to the recurrent laryngeal nerve, those tumor should be removed during pregnancy, and as I mentioned before, preferred during the second trimester. So back to our patient, our young lady, 9 weeks pregnant, who came with suspicious thyroid nodule as well as suspicious cervical lymph node. So as I mentioned to you, the ultrasound of the nodule itself was very suspicious. It was very close to the esophagus here, and also close to the strap muscle anteriorly. So she underwent biopsy of the left thyroid nodule. Also, she had a very suspicious cervical lymph node. She underwent left cervical lymph node biopsy with the TG washout. Cytology came back positive for papillary thyroid cancer from the thyroid nodule as well as the cervical lymph node. And her TG washout was another confirmation. Came back more than 4,000, confirming metastasis to the cervical lymph node. So patient underwent total thyroidectomy, central neck dissection, and left neck dissection in her second trimester, which was actually 26 weeks. And as expected, did show a papillary thyroid cancer with some extranodal extension, and cervical lymph node were involved. Her staging was T2 and 1B. Patient did well post-operatively. She had transit hypocalcemia, but otherwise she did well. She had her baby later on, and 2 months after delivery, she went for radioactive iodine ablation. So the take-home message is a pregnant woman found to have thyroid nodule should be evaluated the same way if she were not pregnant. The only thing different that we do not do radioactive iodine or thyroid uptake scan during pregnancy because it's contraindicated. Thyroid fine needle aspiration during pregnancy is safe. In general, low-risk thyroid cancer during pregnancy can be monitored by ultrasound, and surgery for the thyroid gland can be done after delivery, and that should not change the outcome of the thyroid cancer. However, large thyroid cancer with aggressive behavior with metastasis to the cervical lymph node should be treated aggressively by thyroid surgery during the second trimester. I would like to thank our team in the Thyroid FNA clinic. I would like to thank you for your attention, and happy National Day to our brothers, sisters, and colleagues in Saudi Arabia.
Thank you very much, Imad. Thank you very much, Muhammad, and indeed very happy National Day for our brethren from Saudi Arabia. I think we do have some questions here, and I will kickstart one for Muhammad Bashir. One of the delegates is asking, is carbimazole safe in first trimester of pregnancy?
All right, so can I just explain this area a little bit? Because there are regulations and guidelines. There are regulations and guidelines that says, both carbimazole and PTU can be associated with congenital malformation. However, these authorities, those guidelines said that PTU is preferred to carbimazole because of the lower risk of congenital malformation. However, what I want to say here is we don't have any strong evidence to link these medications to congenital malformations. And there are, most of the studies have been observational studies, and there are a lot of gaps in them, including a huge amount of selection bias. And there's a very important factor that has not been taken into account is how much of this congenital malformation is related to the thyroid abnormality per se, and how much is related to medications. Furthermore, depending on where the studies came from, if a certain medication causes a congenital malformation, you will see, for example, diabetes causes certain form of congenital malformations that affect the heart, for example. So if a certain medication causes congenital malformation, you will expect that all these congenital malformations to be consistently found in all populations got studied. That's not the case. You find form of malformations in Korea different from what's seen in Europe, different than what's seen in other countries. So there is no consistency in these areas at that point in time. So the evidence is very poor right now that these agents cause congenital malformation. They could be, however, we don't know how much is the thyroid problem, how much is the carbimazole problem. So to put things in context here, we don't know 100%. However, if the woman got pregnant on carbimazole and she is stable, what we try to do is stop it as soon as we can. Regardless, whether PTU or carbimazole, we need to taper the dose or stop it as soon as we can. For women who has a very severely uncontrolled carbimazole, uncontrolled hyperthyroidism, I don't mess around with them. That's my personal practice. I don't mess around with them and switch them from agents, from carbimazole to PTU, because I think in the absence of very strong evidence, I think messing around and moving things around might actually, because we don't have a very strong converting kind of formula to go by, I will risk the chance that the woman hyperthyroidism is going to get worse. And we know that that has a higher impact on the chance of the pregnancy continuing anyway, because the, again, poor placentation, high risk, very high rate of miscarriage with a very poorly controlled hyperthyroidism. So without confusing you that much, if you're treating the woman at this point in time, the recommendations are before pregnancy, continue and maintain the woman in PTU. The recommendations in pregnancy is to switch it around, but that's not always practical and that's not always doable. I think the main thing we need to focus in is to try to reduce and stop the medication completely as soon as the woman gets pregnant. But the link is not really strong, is not consistent, and the jury is still out in this area.
Thank you very much, Mohammed, for great elaboration. Imad, question from the esteemed Dr. Ahmed Hassoun. He asked you, using TIRADS score 4 or intermediate suspicion by ATA criteria, size 12 millimeter longest dimension, do you recommend FNA in normal in the context of normal TSH? And if yes, when?
We don't recommend the biopsy for such a patient. Usually size at least 1.5 for the intermediate suspicion American Thyroid Association guidelines, and above 2 centimeters for TR4, thyroid 4. So thyroid FNA is not recommended, and yeah, I think just to monitor with the ultrasound.
He's adding that in the context of the normal TSH. Does that matter? What about the TSH being not normal, i.e. being 5 or being 6? Just to add a bit of...
All right. Yeah, so again, it won't change my management, whether, you know, I mean, based on the size and the ultrasound features, this nodule should not be biopsied. I mean, the only thing might consider changing my management if the patient has suppressed TSH. Then if this is the issue, then this patient should have a thyroid uptake and scan after delivery to rule out hot nodule. But yeah, I don't think at this size with this level of suspicious on the ultrasound feature, biopsy is not recommended.
Ahmad, again, another question from another colleague, Dr. Omar Abu Higla. He asked you regarding your index case, your clinical case scenario. He stated that it is obvious from the ultrasound that this lady is having stage 4 thyroid cancer with extrathyroidal and lymph node metastasis. What was the indication for TG washout?
Yeah, so for the TG washout, I don't think it's like like a routine procedure. We do it whenever we do thyroid biopsy, because in our experience, whenever you do biopsy from the thyroid nodule, it's like an extra needle. We send it for the TG washout because from, again, our experience, we found that we might miss thyroid cancer in the thyroid nodule biopsy in about 26%. So TG washout is just like an additional tool to confirm the diagnosis. 26% of the time, if you do the biopsy only, you might miss metastasis to the cervical lymph node.
Okay. Another question, Ahmad, from Dr. Awad Al-Qahtani, saying, thank you, Dr. Ahmad, and all. What is the best timing in giving an ablative dose of radioiodine post-delivery, considering breast absorption of iodine?
Yeah, so this is an excellent question. Lactating breast is actually might uptake the radioactive iodine. So that's why we ask the patient actually to stop, the breastfeeding at least 2 to 3 months before we proceed with the treatment with the radioactive iodine. Because yeah, lactating breast might take the thyroid radioactive iodine.
Okay, thank you. Question to Mohammed Bashir. One colleague is asking, is there any harm from treating subclinical hypothyroidism, i.e. what are the pitfalls and what are the bills? Mohammed.
The question is, well, there isn't, however, that we know of. However, why will you do that? Well, so if you take this logic, there will be no harm of giving a lot of treatment for patients. But why will you do that if there's no benefit? So those patients will be dragged to hospital to do blood tests every 4 to 6 weeks. They will have to go through the stress of taking the medications early in the morning. And we all know that this is something that the patients find completely difficult to comply with. And so it has a problem with cost and had a problem with psychological stress on the mother. But why will you do that if there's no benefit of treatment? It's exactly the same will apply for subclinical hypothyroidism outside pregnancy and elderly. We don't have any evidence to support treating those groups. We don't argue that will we actually treat them because there is no harm. We know there is no benefit of treatment. So I don't think we should go out this way. So there is evidence right now lacks outside the first trimester, particularly outside the first trimester. So hence I don't normally treat those patients. I might select some of them to treat them later on, not because of pregnancy benefits. So if a TSH was high, repeatedly high, mid-second trimesters, I will treat the women who have diabetes, because hoping that with treatment, hoping with no evidence that those patients might improve a little bit their insulin sensitivity, whether they have type 2 or they have gestational diabetes at point in time. But apart from that, I don't normally treat them.
Muhammad, if I add to his question a sort of another sort of dimension regarding those patients outside the first trimester with elevated TSH, would you put the anti-TPO antibodies into your consideration when you make the decision? Does it affect your, in other words?
No. And I think the more we learn about anti-TPO antibodies, the more we'll know that they're absolutely useless. Apart from telling you there is an autoimmune process, they don't tell you anything, whether inside or outside pregnancy. From my point of view, I don't see the point of measuring them. However, the most recent, the evidence for the studies that showed benefits from treating anti-TPO versus no anti-TPO, I just showed you an example of that. The evidence is very poor. However, the largest meta-analysis that was done quite recently basically showed that, well, whether there is anti-TPO or no anti-TPO, there was no difference. And if there was any benefit seen, it was seen in both patients, which is the early reduction in pregnancy loss. So it doesn't make any difference. The only thing will make difference with the anti-TPO, you might need to monitor the TFTs throughout pregnancy a little bit down the road. They might become florally hypothyroid, but apart from that, they will not dictate what we do. In the past, few years ago, when we were treating those patients, when we get a subclinical hypothyroidism in the first trimester, we used to send anti-TPO before deciding on treatment. But that is gone now. We don't do this anymore. We treat all the subclinical in the first trimester, regardless of their anti-TPO status.
Can I add something?
Yes,
please.
Go on, Imad.
Yeah,
you are welcome to do that.
Treating subclinical hypothyroidism, there was only one study that showed improvement in the outcome of IVF. So before pregnancy, patient with subclinical hypothyroidism, there was a small but randomized clinical trial proving that treating subclinical hypothyroidism will improve the outcome of IVF. But that is before pregnancy. And it was like a small study. I think they have only like 12 or 14 patients, and they treated him and they proved increase in the outcome of the IVF. So this is one of the conditions that I consider treating with the levothyroxine.
Any comment, Mohammed Bashir, especially? I think there is a lot of pressure for such cases. Many of them actually are sort of high profile ladies. And you do have a quite Thrive IVF program in your center, Mohammed. Does the fact that the anti-TPO and the other parameters affect your decision, or do you adopt the same approach?
So let's dissect this into two parts here. So if a woman has subclinical hypothyroidism and she's not pregnant, she should be treated. All right, so she should be treated. You should keep the TSH under 2.5 all the way through that before pregnancy, because that will reduce her fertility rate. The evidence is from IVF patients, but still the practice and the recommendations are all women and in childbearing age, they should be treated. Now, so that's before pregnancy, subclinical hypothyroidism, regardless of anti-TPO positive or negative. Now, when we're talking about euthyroid anti-TPO positive cases, the evidence now it's emerging and it's very strong. 2 randomized control trials, 2 different populations, when large numbers, there's no benefit of treating those women. And the women in these 2 studies were women who are, we consider them high-risk women who have multiple miscarriages or have been battling subfertility for a longer period of time. So those women, there was no benefit of treating them with levothyroxine. So the current practice of treating them is not justified, and the evidence is in those 2 is very strong in this regards.
So despite the evidence is not justifiable, Mohammed, for other sort of reasons, would you just, be on and treat these patients just for benefit of doubt in selected cases?
It's like every single thing that you have, you take it case by case basis, and you can make your own judgment based on case by case basis. So it's left up to your judgment. However, as far as we know, that there is no causal relationship or causality relationship between anti-TPO and miscarriage, as I just showed you, because treating those patients didn't make any difference. So as long as we understand that, sometimes from a psychological point of view, pressure point of view, some people will curve in and will start treatment. Some patients are very, 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 very desperate and stressed and psychologically attached, and they want to be treated. So I think you judge it case by case basis, but categorically, the evidence is no benefit of treatment.
Thank you very much. Question to Imad. I think we are just very much racing with time. It is a sort of a statement saying, if you have a high-risk thyroid cancer who needs surgery and radioiodine pregnancy, how would you approach this?
So basically, we do surgery, prefer in the second trimester, and to debulk the tumor, and the radioactive iodine should be postponed till after surgery.
Another question quickly, Imad, stating that if the nodule not indicated for biopsy, when to repeat ultrasound?
Again, if it's a suspicious nodule, we should do it every trimester. If it's not suspicious nodule, we usually just defer any workup, any ultrasound till after delivery, according to the same guidelines we use for thyroid nodule in non-pregnant.
Another quick question. If the nodule not indicated for biopsy, when to repeat the ultrasound?
So yeah, same thing. Yeah, usually after delivery. Yeah, no, if it's it's not suspicious, just do it as a non-pregnant after delivery, like a year or so. Just depends on the size and the ultrasound pattern.
Two quick questions back to Mohammed Bashir. You mentioned in your presentation that FT4 is estimated and affected by albumin and globulin. So how do you approach cases of hypothyroidism in hepatic failure or in other low albumin level states?
Well, hypothyroidism is managed throughout pregnancy based on the TSH, not the free T4. Generally speaking, we manage hypothyroidism based on the TSH, not the free T4. So the judgment based on the titration up and down in the TSH. So at this point in time, free T4 doesn't matter much.
So another quick question related, just to reaffirm the person who put the question, is a treatment for very low T4 with normal TSH indicated during pregnancy?
Okay, so this is a category that's been known as isolated hypothyroxemia. That's been showing up in the guidelines recently, and I particularly ignored it because I think there is no evidence that this category exists. Basically, I've shown, or there is any harm with it. Basically, I've shown you early on that the rise in thyroid binding globulin sucks the free T4 from the bloodstream, and we know that the TSH is extremely sensitive to small changes in the free T4, and hence we expect the TSH to respond to any particular changes in the thyroid hormone. So this is an analytical problem, unless there are studies that used mass spectrometry or went to do the hard way work of doing the equilibrium dialysis to confirm that we actually have a hypothyroxemia with a normal TSH, and to confirm that this is actually a problem, a condition that's associated with any problems with complications in pregnancy. I think this is a completely analytical issue to do with the assay you're being used, with the physiological changes in pregnancy, and so far there's no strong evidence to support the treatment or even for me the existence of this condition at this point in time. So I think, but as things are progressing and we're going more and more towards studies in some endocrine journals that mandating the use of mass spectrometry whenever new studies are coming, we will be having a better evidence and will be more well informed in the future about the existence of this condition and whether or not it is associated with any adverse pregnancy outcomes.
Okay, two possibly final quick questions just to reaffirm, I think, earlier messages which has been put forward both by you. The first one is to you, Muhammad. Should we offer thyroxine to women who are euthyroid with positive thyroid autoantibodies but has history of recurrent miscarriage? The second is for you.
As I reiterate what I said, the clinical studies that were done both in England and the T4 for Life in the Netherlands took this exact type of patients, recurrent miscarriages. They had to have 2 or more recurrent miscarriages, or IVF, patients with who have failed IVF multiple times, gave them levothyroxine, no benefit in the live birth rates and no benefit in reducing the rate of miscarriages. So there's pretty much no benefit. And as I just stated early on, the impact seems to be of levothyroxine. It seems to be it works more if you started before pregnancy. And we've shown that that is not the case. It doesn't help in those patients. And if you started in pregnancy, it has to be started as early as possible. So from this point of view, there's no benefit of treating those women with levothyroxine.
Okay, Imad, question for you. Dr. Muhammad Ali Ibrahim is asking, I have a pregnant lady in first trimester and FNA biopsy result showed PTC. Is it safe for surgery?
As I mentioned, if it's a low risk, if it's a small tumor, low risk for, we can just monitor by ultrasound every trimester. And if no significant increase in size, we can just offer the surgery postpartum after delivery. If it's showing any signs of growth, or if it's a locally advanced tumor close to the trachea, close to the recurrent laryngeal nerve, if it's associated with cervical lymph node metastasis or any distant metastasis, this is a sign of aggressive tumor, and it should be deal with during pregnancy, and this patient should be offered a total thyroidectomy during the second trimester.
Okay. Muhammad, quick one again to reaffirm an earlier message. One of the colleagues is asking, if I have a patient pregnant 4 months with a slight elevation of T4 and a slight low, possibly he meant TSH, but he hadn't written it, then no clinical sign of hyperthyroidism. Did you start medicine and what dose? Thanks a lot.
Sorry, so the answer is, as long as the patient is asymptomatic, the free T4 levels could be kept up to 1.5 times the upper limit of normal. So, so if in our assay, it's about upper limit is about 20. So you can, we can tolerate up to 30 picomoles per liter, as long as the patient is asymptomatic. And when I say that she doesn't have symptoms and her resting pulse rate is normal, and she's gaining weight, normal weight in pregnancy. So asymptomatic with a normal progression in pregnancy, I will not treat them because I think the risks outweighs the benefits for the mothers. However, if the mother has any of these features, I will treat her with the smallest possible dose, and I will normally start with 5 milligrams of carbimazole and build on that. If it is as he just told me, but the smallest possible dose is what I will normally do.
Okay, just a very final sort of question to you, Mohammed Bashir, because we are just 10 minutes over time and we have to conclude. One colleague is asking, so more or less related to this question you have just answered, newly diagnosed hyperthyroidism in first trimester pregnancy, and patient is symptomatic, but TSH level is just 0.1 and T3 and T4 are both high. What is the treatment plan?
Okay, so here it's this, the most important part is to differentiate between, is this a gestational, if the TSH is not completely suppressed, all right, not completely suppressed, this is probably gestational changes of the TSH. So checking an anti-TSH receptor antibody will be the way to go. So if you don't have anti-trap over in your, wherever you're working, then if the patient is very symptomatic, you might use a small dose of beta blockers, relieve her symptoms and monitor the free T4. If it is gestational changes, the free T4 will come down very quickly. If it is not, the free T4 will continue to rise. Then you can start treatment as to pass the first trimester with carbimazole. And as I said, I will use the smallest possible dose and take it from there. So before the anti-trap, that's what we used to do. Give a small dose of beta blockers and monitor the free T4. But now the anti-trap made our life easy. And if the anti-trap is negative, we know it's not a primary thyroid problem. But as I said, the treatment decision for the patient with thyroid disorders has to be taken into account the symptoms and the free T4 as he elaborated, and has to look at the risk-benefit ratio and as much as possible have a very high threshold to start and a very low threshold to stop treatment in those women.
Okay, I think we have to stop here for sake of time. Would like to thank Viad Akram from ICOM and his team for organizing all the logistics for this very fantastic thyroid update session. And I would like to thank my colleagues and friends, Dr. Imad Naim and Dr. Muhammad Bashir, for providing such a very fantastic presentations. And I would like to thank everybody who has taken the time and effort of joining us and also participating with very actually live questions and debate. Thank you very much. Thanks, Imad. Thank you, Muhammad Bashir.
Thank you.
Thank you, Ziad. All have a good night. Thank you very much. See you tomorrow.
Good night.
Thank you very much. Thank you. Thank you, everybody.
Bye.